Hi, everyone. My name is Piotr Kramaz. I'm the Deputy Chief Scientist of ECDC, the European Center for Disease Prevention and Control in Stockholm. And it's my pleasure to open this webinar, ECDC EUPHA Roundtable on vaccination as a key prevention strategy. It's my pleasure to co-chair this webinar together with Professor Maria Gańczak. We are here first and foremost to celebrate the success of vaccination. I don't have to convince this audience of the value of vaccination. I will be preaching to the converted. And I think what happened during the COVID-19 pandemic has shown the value of vaccination. I had a chance to see it and participate to some extent in this process because I've been part of an ECDC pool of emergency managers for COVID-19. So for the last 1.5 years, I had a chance to see the process and participate in the process of deployment of COVID vaccines in the European Union from the preparedness phase through determining the target groups, initial target groups for vaccination, for giving guidance at different stages of the vaccination programs on the booster doses, etc. And I think me and a lot of us could observe the remarkable success of these vaccines in preventing especially the severe outcomes of the virus in terms of hospitalizations and admissions to the intensive care units and deaths. But the value of COVID vaccines goes well beyond the health impact, and this applies to not just COVID vaccines, but to the other vaccines. So I would like to ask my distinguished co-chair, Professor Maria Gańczak, to tell you a little more about what we will talk about during this roundtable. Maria, please.
Yes, hello everybody. My name is Maria Gańczak. I'm an academic professor, and I'm the Vice President of Infectious Disease Control Section of EUPHA. Today I have this unique pleasure and privilege to co-chair this session with my charismatic colleague from the ECDC, Piotr. I will just maybe concentrate on our main topic today, which is vaccination as a key prevention strategy. And I will refer to our hero, which is vaccine. It's hard to estimate the real value of vaccines. They have reduced enormously the burden from communicable diseases and associated mortality. Each year, about 3 million lives are saved thanks to vaccination. They have helped us to eradicate smallpox, to eliminate polio from most of the continents, and to control many infectious diseases such as tetanus, pertussis, diphtheria, hepatitis B, and many, many others. And we've got to think about the impact of vaccines, not only with bearing in mind the perspective of individual benefit, or even clinical benefits, or more broadly in terms of public health.
The value of
we should also add this economic terms, such as reducing healthcare expenditures, decreasing, for example, lost labor force productivity, or contributing enormously to social and economic development. And our four distinguished speakers today will talk more about these economic aspects of vaccinations. We will listen to some talks related to the global return of investment in immunization. We will also listen to some other presenters who will talk about economic value of immunization, but also about how vaccines contribute to minimize some very important emerging infectious threats, such as, for example, antimicrobial resistance. However, all these aspects will not matter if people refuse to use vaccines. Therefore, our last but not least speaker will concentrate on vaccine acceptance, and they will try to convince us that it's worth to invest in vaccine acceptance. So having said that, I will turn you over to Piotr.
Thank you very much, Maria. Before we start, I would like to give you a few housekeeping notes. We'll have 4 speakers. We have 1 hour for this session, so maximum 10 minutes per talk. The first talk is recorded. Unfortunately, Professor Blum couldn't be with us in real time, but you will see his presentation. Importantly, the discussion we will move to the end. So please enter your questions into the Q&A part of the website, and we will then read them and ask the presenters to answer them after all the presentations. And for the presenters, please remember to switch on your camera before presenting and then switch it off. And then for the end session, I think we'll all switch on our cameras. So with that, I would like to introduce our first speaker. It's Professor David Blum. He's a professor of economics and demography in the Department of Global Health and Population at the Harvard School of Public Health. Dr. Blum is an economist and his work focuses on health, demography, education, and labor. Could we have Professor Blum's presentation, please? Let's start.
Good day, ladies and gentlemen, and thank you for indulging my participation in European Public Health Week. I especially want to thank the European Public Health Association and the Vaccine Preventable Diseases team at the European Center for Disease Prevention and Control for offering me this chance to comment on the value of vaccines and vaccination. I apologize that a prior commitment precludes me from joining you live. I plan to make 2 general points this morning, both of which are applicable to vaccines and vaccination. The first point is that health technologies that promote and protect population health have been routinely and substantially undervalued. This has led to worldwide and decades-long underspending on public health programs, as well as to underspending on health-related technological and institutional innovation. And my second point is that a key step toward remediating this deficiency involves changing the way we conduct health technology assessments. Let me crack into the undervaluation point, which is intimately connected to the health and wealth of populations. So we all know that healthier populations tend to have higher incomes and greater wealth than their less healthy counterparts. The causal pathway from health to wealth is clear. It's clear insofar as money is a well-established and first-order driver of improvements in nutrition, increased access to safe water and sanitation, and better access to more and better quality healthcare services. But there's another pathway linking health and wealth that has come to the fore more recently. This pathway, which is well supported by theory, evidence, and common sense, runs in the reverse direction, from health to wealth. This is a supremely important point. It's important because it takes an old view of health spending as a weighty albatross around our budgetary and fiscal necks and transforms it into a new view of health spending as productive investment. This new finding is well summarized by the tagline, "Healthier means wealthier." It reflects the fact that healthy populations have higher labor productivity, better education sector performance, and higher rates of savings and investment. It also reflects the fact that healthy populations are better able to escape the crushing burden of youth dependency, and they tend to be more stable, cohesive, equitable, and secure. Now, until recently, this claim about academic research demonstrating population health's sizable follow-on economic and social benefits would probably have been deemed speculative and perhaps even controversial. But the experience of COVID-19 has taken out of academic circles and made self-evident to policymakers and people throughout the world the effects of health issues on everything from productivity and income to peace of mind and social and economic inequities. COVID-19 has provided incontrovertible evidence of the negative effects of health risks on income and schooling, and thus on our current and future standards of living. In addition, by dramatically diminishing people's sense of safety and well-being, the pandemic has demonstrated the high cost of anxiety caused by health risks. And COVID-19 has greatly increased awareness of social and economic inequities, both within and across countries, in risks of infection, access to quality healthcare, and social injustice more generally. COVID-19 has revealed these truths throughout the world, in line with the heavy health, economic, and social tolls imposed by the pandemic. The whole world now has a compelling shared and lived experience that intuitively demonstrates and confirms 2 decades of economic, sociological, and political research pointing to health as not just a consequence, but also a cause of national development, and of health as both an indicator and an instrument of human progress. Now, if you accept my contention that we've undervalued population health by neglecting or giving short shrift to its economic and social benefits, it stands to reason that we've also undervalued health interventions. Redressing that situation is in the interest of promoting efficiency and equity in the use of social resources. It's also theoretically justifiable and eminently achievable. For starters, it involves changing the way we set the size of health budgets and the allocation of those budgets across different programs. The key here is to conduct health technology assessment, or HTA for short, to conduct HTA in a way that rectifies our long-standing and widespread failure to account for the full societal burdens of health limitations, which fundamentally define the full societal benefits of health interventions. In this connection, I believe that we're in the initial phases of a process of social change that involves a decisive shift in the way we conduct health technology assessments. To my mind, this process of social change is more fundamentally revolutionary than evolutionary. It involves a shift away from standard health-centric cost-effectiveness analyses in favor of society-wide benefit costs and return on investment analyses. The shift is also starting to show unmistakable signs of greater distributional sensitivity. In other words, greater attention to the ethical implications of different societal outcomes. This distributional sensitivity is manifesting itself in a growing reliance on social welfare functions, which I expect to become a core part of the methods economists use for HTA in the coming years. The core principle at the heart of this process of social change I'm discussing involves the rational and feasible adoption of a broad perspective on benefits. It applies to health interventions ranging from medical devices and pharmaceutical drugs to health system strengthening. It also applies to non-health interventions such as transport, communication, energy, and schooling. And it most assuredly applies to vaccines, irrespective of whether they're targeted at children, adolescents, adults, or older people. I also want to spotlight my concern that vaccines are specifically disadvantaged by the narrow health perspective that has dominated HTA for decades. This narrow perspective does not adequately reflect the time horizon for enjoying the benefits of avoiding childhood infectious disease, which tends to be much longer than for the prevention and treatment of disease among, for example, older people. It also does not reflect the fact that vaccination against infectious diseases tends to have substantially larger externality benefits than interventions against for example, non-communicable diseases. Put another way, the world has for decades been using a defective HTA yardstick to guide decisions about vaccination programs, and this has generally led to a suboptimal allocation of social resources. The good news is that remedying this defect is absolutely within reach with routine tools and with data that are either currently available or easily collectible. Based upon my ongoing review of the literature, I can also assure you that with few exceptions, studies that target the full societal value of vaccination, as opposed to narrow health and health system benefits, point to much elevated rates of return, thereby justifying significantly larger vaccine budgets. In closing, I'm simply noting here that public health programs typically involve public costs, and I'm simply arguing for greater appreciation of the fact that public costs are most naturally and appropriately compared to public benefits, to full public benefits, and not just a fraction of them. This means adopting a broad societal perspective to guide the conduct of HTA, which are a key ingredient in our collective spending on and investments in health. I'll end here with a thank you to you all and conveying my good wishes for the remainder of the session. Bloom over.
Thank you, Professor Bloom, for your very comprehensive and interesting talk. Now we will move to the next speaker, who will be Professor Mark Jitt. Professor Jitt works at the Department of Infectious Disease Epidemiology at London School of Hygiene and Tropical Medicine. He worked for Public Health England and Health Protection Agency. His main field of interest focuses on epidemiological and economic impact of vaccines to support evidence public health decision-making. He collaborates with decision makers such as the World Health Organization, country governments, but also some national immunization advisory boards. And his work helped to improve immunization policies regarding numerous vaccines, such as, for example, COVID-19, HPV, measles, influenza, rotavirus, dengue. He is also working in both developed and developing countries. And now the major focus of his research interest is COVID-19 pandemic and the ways to mitigate it. Professor Jitt, the floor is yours.
Great, thank you very much for that introduction, and thank you for the invitation to speak. I'm really delighted to be part of this week because we all know how essential the issues we're considering around vaccines are, well, as Professor Bloom has just said, not just in the field of health, but actually to the very basic functioning of our societies. So what I'm going to speak about today is actually what are the issues we need to consider when we look at the economic value of vaccines. And if I could have the first slide, the next slide, please. When we're thinking about vaccines, the first thing I want to talk about is what do we mean by the value of a vaccine and how do we measure this value? And so when economists ask how we measure the value of a health intervention, what we do is we conduct something called a health economic evaluation. What a health economic evaluation is, it's really a method to compare two kinds of worlds. And these two worlds change depending on the decision that we make about a health intervention. And so let's take a vaccine, for instance. Let's say a new vaccine comes on the market and we want to decide, is this vaccine good value for money? How do we do this? Well, we compare a world where we don't introduce the vaccine. What does that world look like? If we don't introduce the vaccine, then what we do is we have a certain burden of disease. We have the disease, which costs money because it actually costs money to treat the disease. People who get the disease are unable to work, so that it costs the economy something. And also there is also an additional health burden. So the burden of disease is not purely in financial terms, in terms of we need to treat it, people lose productivity, but actually inherently people do not like to be sick, even if it costs nothing to treat them. I mean, sickness is an undesirable attribute that we want less of in its own right. And so we have the cost of illness and the health burden. Now we look at a world where we introduce the vaccine, and how does that differ? Well, one difference is we have to pay for the vaccine. We have to pay to buy the vaccine and to deliver it. So that's an additional cost. But then the cost of illness, the cost of treating the disease, the productivity cost of the disease drops because the vaccine is preventing a lot of this disease. And so the health burden also drops. And so we compare these two worlds. We say, do we prefer to be in the world on the right where we have less burden of disease, where we pay for the cost of the vaccine? Or do we prefer to be in the world to the left, where we pay much more for the burden of disease? And an economic evaluation actually helps us compare these two worlds and say, okay, which is a better world to be with in terms of value? So what about vaccines? When we do these calculations, how do vaccines look? And if we can have the next slide, please. The first thing I want to say is that for many vaccines, these have been proven for over decades to be one of the most cost-effective, best value for money interventions that we have. So actually, over 30 years ago, the World Bank actually commissioned some economists to look at the cost effectiveness, the value for money of some basic health interventions, because they wanted to recommend a package of basic interventions that every country should introduce. And one of the interventions they looked at is something called the EPI Plus package. What is EPI Plus? It stands for Expanded Program on Immunization Plus, which consists of the basic vaccines that WHO was recommending to all countries at that time. So the diphtheria, tetanus, pertussis vaccine, measles, polio, BCG against TB, and hepatitis B vaccine, as well as the plus refers to vitamin A supplementation for children. And what they found was that this package of vaccines was one of the best buys in health, one of the most cost-effective public health interventions that any country could introduce. It cost about $12 to $17 on average around the world to save a whole year of human life in perfect health. So paying an extra $15 or so for a whole year of life, that is the value of these vaccines. So the value of these, what are called the EPI or the traditional vaccines, is very well established over decades. Let's go on to the next slide, please. The picture has become more complicated because the world of vaccines have changed since the sort of 1970s and 80s. The number of vaccines that's available has exploded over the last few decades. New innovations in the vaccine space. I mean, we see the fruits of that in the COVID-19 vaccine space, where we have mRNA vaccines, viral vector vaccines, and so many innovative vaccines all developed within 1 or 2 years. If we can have the next slide, please. However, these vaccines differ. The traditional vaccines, the vaccines we had in the first half of the 20th century, these were very cheap vaccines, easy to make, highly effective against childhood diseases like measles or polio, which actually affected a majority of the world's population in the pre-vaccine days. Probably most of us might be, including myself, are too young to live in an era where these vaccines were common to every child, and every parent would worry that their child might not survive these diseases, but that world used to exist. And they were easy to deliver. Every country soon introduced the EPI program, which would deliver these vaccines to a set age group, infants or very young children. Now we look at a new set of vaccines, really starting with the vaccine against hepatitis B and Haemophilus influenzae, and then expanding now to vaccines against HPV, PCV, dengue, COVID-19, and so forth. These vaccines tend to be more expensive. Well, one, because they're based on more complex technology, and second, because they're newer vaccines, so the vaccine manufacturers need to make back their R&D costs. Sometimes they're against infections which are less common, though maybe not any less deadly, like some of the meningococcal diseases. Some of these vaccines are quite difficult to evaluate because their efficacy is complex. We saw that with the malaria vaccine, which is partially efficacious, but against a disease which really kills so many children. The vaccine against RSV, for instance, had the Novavax vaccine against RSV had some complicated results in phase 3 trials. So COVID-19 vaccines, the efficacy is complex depending on which variants they are combating and so forth. And now we're being asked to deliver these to non-traditional risk groups, not just to very young children, but to adults, to adolescents, to pregnant women, to the older adults and so forth. And so companies need to find new routes in order to deliver these vaccines. Because of that, the value of these vaccines, there's still tremendous value, but it's not such a completely clear picture. Countries are saying it costs us a lot of money to deliver these vaccines. Is it really worth the value, considering that this is not like a measles vaccine, which is combating one of the largest sources of mortality in our country now. And so the picture has become more complex. And because of that, if we can go on to the next slide, I think it is even more important to be very careful about how we measure this value. And this really carries on from the proposal that Professor Bloom made in the last talk, which is really to say, actually, the benefit of, we need to be much more clear about the broad scope of benefits of these vaccines. So the main focus in the past has been looking at the health gains of vaccines and the immediate productivity gains, because people who are sick are not able to work or not able to work as effectively. But actually, if we expand this space, we'll see vaccines have many other benefits that we don't capture so well, such as ecological effects. Vaccines actually can protect not only the vaccinee, but a wider group of people through preventing transmission. Vaccines have an impact on antimicrobial resistance because we can decrease the amount of antibiotics or antivirals that we give to people if there's less disease. Vaccines might have effects on household behavior. For instance, if families know that their children have a high chance of survival, they will invest more in each individual child, and that child will have a greater human capital, probably have better education, be more productive in the future. We saw with the COVID-19 vaccines can have long-term macroeconomic impact in making economies more efficient, in boosting the economic growth. They could have impact on equity because vaccines are easier to deliver than many healthcare services. So countries are able to deliver them to the hardest to reach and most vulnerable population and so forth. We need to be able to capture this wider group of benefits that we get from vaccination in order to really measure the value of these new vaccines well. In the past, it was less necessary because it was so simple that vaccines were such a good value proposition. Now we need to be more careful about these wider benefits. If we can go to the next slide. And so as we're looking at that, I've just listed here some of the sort of broader benefits that we can see from many of the vaccines that we have introduced over the last 10 or 20 years, and the way they have sort of a whole array of benefits that actually we're starting to understand. I mean, epidemiologists, economists, sociologists are starting to understand this wider group of benefits that vaccines bring. So if we can go on to the next slide. So I'm just going to end by summing up some key messages. First of all, understanding the value of vaccines is important. Manufacturers make decisions about whether or not to invest in R&D based on this. Donors decide, for instance, like Gavi or CEPI, they decide which vaccines they're going to invest in based on its value. And countries make introduction decisions based on the value of a vaccine. So we need to be able to measure this value well. With the traditional vaccines, it was very easy. These were some of the most cost-effective interventions ever developed. And all we needed to see was the number of lives we would save if we introduced a measles vaccine or a pertussis vaccine. We would be saving millions of lives around the world for a very cheap vaccine. The newer vaccines we've seen in the last few decades, these cost more than EPI vaccines, but they have very broad benefits, not just on mortality on the individual vaccinee, but much broader benefits on entire societies. And so to be able to measure the value of these vaccines well, we need to be able to capture this broader value. And we are really getting the tools, the epidemiological studies, the trials, the modeling studies in order to measure these broader benefits. So increasingly getting a better picture of them. So thank you very much.
Thank you very much, Professor Jit. I would like to remind everyone that you can enter your questions in the Q&A panel, and we will then read them at the end after all the talks. And with that, I would like to introduce the next speaker, who is Dr. Michele Cecchini. Michele is responsible for the OECD program on public health, and that includes work on preventing unhealthy lifestyles and major risk factors, tackling emerging communicable diseases, antimicrobial resistance, and assessing and providing advice on reforms to improve public health systems. His research interests include priority setting and program evaluation, looking at the impact of policies influencing public health, in particular concerning the health and economic assessment of public health policies across the different sectors. Dr. Cecchini, the floor is yours.
Thank you very much, Chair. Good morning, everyone. It's a pleasure to be here with you all during the European Public Health Week. It's a pleasure for me as a medical doctor, public health specialist by background, but also for the OECD to contribute to this discussion. In particular, thanks to EUPHA and the CDC colleagues for inviting us. Today, I'm going to talk to you about vaccines and the economic of public health with a specific reference to the case of antimicrobial resistance, which was already mentioned by the speaker before me as a potential interesting area in which vaccines can play a key role. Next slide, please. But let's start by looking at how little countries spend, OECD countries and European countries in particular, spend on vaccination, at least in the pre-COVID period. If we look at the graph on the left, on average, OECD Europe, 16 countries spent 12.5 euros per capita on immunization program in 2019. With significant cross-country differences, also including, for differences in what is included in this cost. But overall, on average, across this group of countries, only 11% of the budget for prevention was spent on immunization program. Now, if we consider that generally prevention is the Cinderella of the items on the healthcare budget on a country, on average accounting for 3%, only 11% of this 3% is the commitment of countries on vaccination programs. Next slide, please. But at this point, I would like to get into the discussion on vaccination and AMR. Explaining why OECD, with support from the European Commission, this is a EC co-funded project, started investigating the impact of AMR and also the potential impact of vaccinations and other public health policies on AMR. If we look at European countries, AMR cost 1.1 billion euros per year to the healthcare system of our countries. On average, a little bit less than 2 euros per capita are spent to treat the consequences of AMR. This is mainly consequences in hospitals. People that develop resistant infections stay longer in the hospital, require more intense treatment, are more likely to end up in intensive care units, and therefore they have a higher cost. Of course, the prevalence of AMR across countries is one of the determinants of the cost. So countries with high prevalence of AMR, such as Malta, Italy, for example, have higher cost, but there is also a component that is linked to how efficient are healthcare services in providing the same services. Of course, for a healthcare system that spend more for a given treatment disease, then again, this is another factor in influencing AMR. Now, we know that using better antibiotics is certainly the first and probably most important response to treating AMR, but there is also a key role that can be played by vaccination. Next slide, please. And this is an analysis we carried out a couple of years ago to look at the potential impact of vaccine on AMR. So let's start on the graph on the right. We see that vaccination can decrease the infection rate of AMR based on the literature by a little bit more than 50%. So there will be, following the implementation of a vaccination for a resistant, for a bacteria that is susceptible to develop resistance, we could expect a decrease in about 60% in terms of infection rate following the implementation of a vaccination. The carriage would also significantly decrease, although to a lesser extent. Then the impact would be much higher for the targeted serotypes of the vaccination compared to all the serotypes for the vaccination. Another interesting finding of our work is that the higher the number of serotypes that is targeted by the vaccine, the more effective is the vaccine in containing the infection rate of this infection. So overall, vaccine can more than halve the incidence of infection and decrease the probability of carriage. Serotype replacement is likely to take place following the introduction of a vaccination program, but the replacement does not seem to be complete, at least in the medium terms, and vaccines remain effective. The more comprehensive the coverage of serotype, the higher the effectiveness of vaccines. Next slide, please. And if we look at the policies that countries have in place to tackle AMR, as well as the WHO Global Action Plan on AMR, we see that OECD, EU, and G20 countries, as well as WHO, place a significant emphasis on using vaccination as one of the public health tools that countries can implement to tackle AMR. This is an analysis that we published really a few months ago on how much emphasis National Action Plan and the Global Action Plan puts on vaccination, in particularly improve vaccination coverage for AMR. And you can see that together with support infection prevention and control program, vaccination is certainly the area with the highest emphasis across OECD countries, EU countries, G20 countries, and the national and the AMR Global Action Plan. In the Global Action Plan, in particular, improving vaccination is emphasized as one of the leading strategies to reduce the emergence and the spread of resistant infection. And National Action Plan across these countries are well aligned with the Global Action Plan in terms of recognizing the centrality of vaccines to tackle AMR. Next slide, please. However, if we look at the funding allocated to vaccine, we see that this is relatively low compared to other research and development activities to tackle AMR. And this is data from the Global AMR Research and Development Hub dynamic dashboard for investment for funding the research area in 2020. And you can see that things such as therapeutics or diagnostics tends to have a higher investment compared to vaccine. Globally, around $116 million were allocated in 2020 to support research activities for vaccine development. This represents about 7% of the global AMR relevant research and development funding in the same year. And between 2017 and 20, if we look at the trend, the share remained fundamentally stable at around 7%, again at the lower bound compared to other areas such as therapeutics and diagnostics. Next slide, please, which is really to wrap up my intervention. So the policy consideration and the key messages from my presentations are vaccines are a key public health tool that comes at an affordable cost for OECD countries, the vast majority of cases. Vaccines are effective and can help support broader strategies against emerging infectious threats such as antimicrobial resistance. Countries do recognize the importance of vaccination campaigns, and there is support for a higher use of this tool, at least in the policy documents of these countries. Yet, investment on vaccine is relatively low compared to other research and development activities to tackle AMR. Thank you very much for your attention. I stop here for now. I look forward to the discussion. Over.
Grazie mille, Professor Cecchini. I would like to thank you very much for this excellent talk. And now let me introduce our last but not least speaker, Dr. Jonas Sivela, comes from Finland. For the last 5 years, Dr. Sivelä was working at the Department of Infectious Disease Control and Vaccination at the National Institute for Health and Welfare in Helsinki. And since this year, he is a senior specialist and head of the Cultural, Behavioral and Media Insights Center at this institute. His main field of interest concentrates on vaccine resistance, confidence, acceptance, hesitancy, and he's collecting data mainly on the national level using ethnographic and qualitative methods. He has also broad professional background in communications and journalism. Dr. Sivelä, olkaa hyvä. The floor is yours.
Kiitos paljon. Thank you so much for the kind introduction. Yes, thank you. I will talk about the topic very dear to me, vaccination acceptance. Could I have the next slide, please? So, we've heard very many interesting and important talks about the value of vaccination for society and for health. This is a map not drawn by me, but by a dear friend Bruce Gelling from the US, that shows that the road from vaccine to vaccination is a long and complex one. In the very middle, you see the word vaccine acceptance. I will not go through all the boxes and arrows here, but this is just to demonstrate to you the complexity of the road from vaccine to vaccination. Next slide, please. So basically, when we talk about vaccination acceptance, we mean the degree to which individuals accept, question or refuse vaccination. This can, of course, be understood in very, very different ways. On the right, we have a very nice infographic prepared by the ECDC demonstrating one of these ways, the so-called 5 Cs model, through which we can better understand the factors affecting vaccination acceptance, such as confidence, different constraints. Many of them can be physical or related to convenience, for example, complacency and risk perception, and, for example, collective responsibility. It's very important that when we talk about vaccination acceptance, that we understand that it is much more than only anti-vaxxers or vaccine refusal. Very many things affect if or if not people take their vaccines. Next slide, please. Thank you. This is a word cloud to further demonstrate the complexity of and the very many different sides of vaccination acceptance. We have things from vaccine supply to policies to genders to religion to geographic barriers that all have or can have their impact on the vaccination acceptance and, at the end, vaccine uptake. Next slide, please. Thanks. So what should we do about this? Well, I propose a research-based approach. And it's a very simple one. We have 4 steps. First, we need to identify the problem. The groups or the regions or societies with low or suboptimal vaccination coverage. 2, we need to know why the vaccination coverage is suboptimal. We need to examine the so-called determinants behind low coverage. 3, we need to use this information to develop actions. They can be policies, they can be specific interventions. The bottom line is that they need to be evidence-based or evidence-informed. And in the best of worlds, we will also be able to measure the effect of these actions. So it sounds like a simple road, but it's not necessarily very simple. It's quite cumbersome and heavy, in fact. But by following these 4 steps, we can actually have very good results in strengthening vaccination coverage at the end. The next slide, please. I will use Finland as an example here to demonstrate how we have done in implementing vaccination acceptance related tailored actions. So during the last years, as was told in the introduction, we have put a lot of effort on vaccination acceptance research and also on research-informed activities in Finland. In practice, we have conducted studies on different topics related to vaccination acceptance. We are a member of many international consortium projects, and we have many partners that we work with both nationally and internationally. And all this is done in order to support the work we do at the national immunization program and in relation to the health security policy work in general. And it has resulted in many evidence-informed tailored actions and high vaccination coverage and vaccine acceptance. Next slide, please. So I will give you a couple of examples of such specific actions we have done and research we have conducted in order to support our national immunization program. First, as I said, we need to map the situation. We need to know what's going on. We need to know if vaccines are trusted, who trusts them, who takes them, and what is the level of vaccination acceptance in general. We have done this, for example, by different large-scale population surveys measuring the attitudes and the perceptions about vaccination. Next slide, please. Thank you. We have further studied the reasons behind vaccination acceptance. This is an example relating specifically to the COVID vaccinations, where we have looked in depth on the reasons affecting vaccine acceptance. And we can see that the concern about severe disease was a strong motive, but on the other hand, complacency and worry about side effects were reasons against vaccination. Convenience was a factor that affected also positively or actually negatively vaccine uptake at the end. Next slide, please. Social media monitoring is another example of an action that can be taken in order to strengthen vaccination acceptance and activities related to it. It's very useful if we want to support communications activities, for example. This specific slide and picture is from the EU Joint Action on Vaccination that just ended in the end of March, where this work has been conducted by Francesco Gesualdo from the Bambino Gesù Children's Hospital in Rome. But I can also, from a national perspective, say that social media monitoring plays a key role when we want to develop functioning and successful communication activities and strategies. Next slide, please. We have a lot of proof that convenience of vaccination services improve vaccine uptake and increase vaccination acceptance. Next slide, please. Thanks. We also have a lot of proof from research that reminder systems and recall systems increase vaccination coverage. Next slide, please. But it does work. This is unquestionable. But however, it does not come for free. It requires a lot of investment. It requires human resources and the right kind of competence. Different kinds of researchers from different backgrounds, behavioral scientists from different disciplines, data scientists, public health researchers as experts, programmers, for example, when it comes to social media monitoring, reminder systems and such. It also requires mandate. It definitely requires the support of the organization to basically be able to conduct the work. It definitely requires funding. We need the resources to be able to do this kind of work. And networks are incredibly usable in order to conduct work related to this. But it's not enough that we're able to conduct work related to vaccination acceptance. We also need the ability to digest all this information, all this research-based knowledge about the reasons, for example, affecting vaccination acceptance. And this is something that definitely needs still to be developed in the public health field. Last slide, please. Thank you so much. I just want to demonstrate, as I told you, we need to invest. If we want to do work related to vaccination acceptance, we need to invest in that. And this is a result from the EU Joint Action on Vaccination that from the part that I was working with mainly, where we also examined perceptions about the work and the experiences about work related to vaccination acceptance. And most of the countries considered that they were not able to work with these topics in a way that meet their needs. And this is, of course, extremely concerning and further emphasizes the fact that we need to put more stake and more prioritize this field much more in the future. Thank you. Over.
Thank you, Jonas. Paljon kiitoksia. I would like to open the floor now for discussion. We don't have a lot of time, but we have time for 1-2 questions. And I don't see anything in the question and answer panel. I think the audience is probably stunned by the quality of the presentations and probably also by the complexity of the picture as shown on some of the slides. So perhaps I can ask a question from my side. I would like to ask Jonas, actually, you know, I think we all have seen during the pandemic how important this type of research is, or activity in general, the behavioral insights, the social science, because we could have a very good evidence-based guidelines and recommendations, but without the compliance from the population, they would be virtually useless. So at some point, we looked at the capacity for such activities in the public health institutes in the EU, and the picture was very patchy. Some of the institutes have such a capacity and capability, but some don't. And from your perspective, what arguments could be used to convince the decision makers that this is worth investing into from your experience? Could you tell us a little more about that?
Thank you, Piotr. It's a very good question. And as you said, you really need the support or buy-in from the organization if you want to conduct work or activities like this. It's a challenging environment, the public health field. Traditionally, there has not been very much social scientists or cultural researchers or communications researchers in the field. So it definitely requires a lot of work to sort of convince the organizations that this is valuable. I think it really depends on the context and maybe the country and the organization you work with. But for us and those who I have worked closely with, I think the pandemic showed or proved very clearly that it is simply not enough to have knowledge about spike proteins or pathogens. It is essential, definitely, I'm not saying that, but it is not enough. The people need to accept the decisions, they need to comply with the recommendations. The only way to do this, the work related to this cannot be based on intuition, it must be based on research. And I think this is the only reason, and it's very simple. I don't think we need another reason besides that. But of course, we need understanding that this is something essential.
Thank you very much. Any other questions? I see Michele.
Yes, thanks. Mine is not a question. I wanted to react a little bit to a comment I saw in the chat by the colleague from the Slovak Republic, mentioning fundamentally raising the point that cost-benefit analysis is not something that convince people in getting vaccinated, if I got right, which is a comment that I support. I agree on the point made by the colleague from the Slovak Republic. I don't think the type of analysis that I mentioned, or even pushing it further, what Mark said, is, in my view at least, is the type of information we want to share, or better, we want to use to make the point with the layman that this person should get vaccinated. I think that the type of information we need to convey to the layman, to the general population, are different. Of course, we don't need to hide the information on how cost effective and what are the economic benefits of a vaccination program, but I understand that it probably is not the message that make it through to the general population. The type of analysis that at least at the OECD we do, and other persons part of this panel do, is more to convince government founders that this is the right way to spend, to fund, and to spend money in, because they give a great return for the bucks. Over.
Thank you very much. And I see more comments about the possibility of promoting vaccination through TV, social media, or even talking at school to increase the vaccine uptake among the young population. But I think we are now, we have only very little time left, so maybe let me start wrapping up. It has been a very interesting session with excellent talks from very distinguished speakers. And I think the one thing, the take-home message is that really to evaluate vaccination, we need to go much beyond the immediate health outcomes. And to see the whole area from the broadest perspective, like that of the systems theory, and only this can give us a comprehensive perspective to allow the full appreciation of the value of vaccines. And the other key message for me is that only such broad perspective can help us go beyond some kind of simple notions like blaming the low vaccination coverage on vaccine hesitancy, and what Jonas presented has shown that we need to really look for any potential barrier to vaccination, and then address these to really increase the uptake and acceptance. Maria, any thoughts from your side?
Yeah, I would say, wow, what a kaleidoscope of thoughts, ideas, key messages, approaches, etc., delivered by our distinguished speakers, which I would like to thank very much. So I think that now we are more closer to really recognize that vaccination is the key prevention strategy. And it will really be not only addressed, but also appreciated. And the take-home messages delivered by all speakers call for a sort of change of our understanding of the value of vaccines. I think that there should be a shift in minds and budget, because as all our speakers state, vaccine is the most cost-effective public health intervention after clean water. So governments will have to secure their budgets to guarantee the universal and equal access to vaccination. Secondly, there should be the shift in evaluation, because as some speakers said, vaccination means health, and health means wealth. So we should really don't forget about this microeconomic aspect of vaccinations, which was nicely expressed by all speakers. And finally, there should be a shift in perception of vaccine acceptance. We now know that it's a sort of investment, but it's an investment which really, according to the evidence, pays off. So these are my closing remarks, and then over to Piotr.
Thank you very much. And both Maria and myself would like to thank everyone for this session. Our EUPHA colleagues, Annemieke, Sivelä, and others who made this happen, Karam Adel Ali from ECDC, all our distinguished speakers for the excellent talks, and the whole audience for participation and questions. Thank you very much, and have a good rest of the day.